Good morning. Good morning and welcome everyone. I'm Helena Hansen, Interim Chair of Psychiatry, Interim Director of the Semel Institute for Neuroscience and Human Behavior. And it's my distinct pleasure this morning to introduce someone I've known, I think almost 2 decades now. I'm going to tell two different tales of Dr. Brian Anderson. The first tale is how I came to know Dr. Anderson, which was almost 2 decades ago when I met him as a very promising and emerging anthropologist, actually, physician anthropologist in training. He was working with a dear friend of mine, Angela Garcia, who's a quite famous anthropologist and doing field work on the indigenous, traditional, and religious uses of ayahuasca in Latin America. And so I came to know him as somebody who's incredibly thoughtful and theoretically sophisticated about medicine in cultural context. What I did not know is that in the years that ensued after that, he would be building a very distinguished career in path-breaking work on the therapeutic uses of psychedelic medications. And as we know, that those uses have gained more and more attention as psychedelics as a treatment modality have really been brought into more of our mainstream psychiatric practice. And that's a whole story that we may hear some of this morning from Dr. Anderson, who's really been at the forefront of making that possible and working, for example, in what used to be a hostile landscape of federal funding for psychedelics clinical trials, working behind the scenes to make those trials possible, collaborating with donors in the private sector. He's been doing a lot of impactful work. So here is his official bio. Brian Anderson, MD and Master of Science, is an attending in the psychiatric emergency services at Zuckerberg San Francisco General Hospital and an associate professor of psychiatry and of palliative medicine in the UCSF School of Medicine. He's a founding investigator, as I was mentioning, at the UC Berkeley Center for the Science of Psychedelics and is affiliated with UCSF Neuroscape and the UCLA Ecological Medicine Initiative. So I hope we get to hear a little bit of that, of his collaborations, which are pretty durable here at UCLA. At UCSF, he directs the Compassionate Use Research and Advocacy Cura Lab, which seeks to transform how we address suffering and despair among people living with serious and life-threatening illness. He's served as a subject matter expert for government bodies and as a corporate officer for several nonprofit organizations that seek to improve the safety of communities of people who use drugs. And I am going to guess including those who use psychedelics for therapeutic purposes. So we are very excited and honored to have Dr. Brian Anderson. Thank you and welcome.
It's great to be here. Thank you so much. So I'm going to present this talk, Psychedelics, Novel Challenges and Solutions in Regulatory Science. I made this talk for today. This is my first time giving this lecture. Well, let's start with disclosures. So I am going to be speaking about some non-FDA approved uses of medications, specifically psychedelics. You can see my research funding here from government sources and from philanthropy. And for the learning objectives, so we're going to first cover what is the current status of psychedelic therapies for mood disorders, specifically in patients with serious medical illness. Then we're going to transition to some thoughts about how to evaluate methodological limitations and opportunities in psychedelic regulatory science. And I'll say a little bit more about what that is. And then I want to end with some thoughts on what I think could be impactful real-world studies with psychedelic care. So we're going to go to the first section. So psychedelic therapies for mood disorders in patients with serious medical illness. One way I want to kind of get us to jump into this is I'm going to briefly talk about a case from one of our trials that we did at UCSF a few years ago. This was a study of psilocybin-assisted group therapy with long-term AIDS survivors. And so this is a man who was in his 60s, long-term AIDS survivor, meaning he had HIV/AIDS before we had available highly active antiretroviral therapies. So everyone in this cohort was told that they were going to die within months to years. They were end-of-life patients at one point, but then these medications came along, or people were resistant and were able to live to become older. This gentleman came to the study not having any psychedelic experience, actually being pretty anxious about psychedelics, but definitely coming looking for help with mood symptoms, anxiety, and a lot of isolation, which is something that really plagues this population. In this study, our primary outcome was the demoralization scale. And so just briefly to track his what happened for him, he was actually pretty severely demoralized, which we'll talk more about what that is later, but he had severe levels of this at the beginning of the study. And then at baseline, after 4 group therapy sessions, he was not getting better. But when you see that steep decline, that is between the 4th and 5th group therapy session is when people had their individual psilocybin administration day in the study, and his symptoms really responded quite rapidly, but then sort of got worse again over time as we followed up. This gentleman actually had a pretty challenging psilocybin day. By the end of it, he was in a state of just actually a lot of sort of positive feelings and was expressing his emotions in a way that he hadn't earlier in the study. But then, this is not a magic pill. It didn't make everything better. And he actually, in the middle of the study, had a recurrence of life-threatening cancer that he didn't even feel he could talk about with the other members in this therapy group because it was so hard for him to process. His words were, though, that if he had had that recurrence without the psilocybin, it would have been much more catastrophic. And so he actually really found benefit of having the support while dealing with that challenging, life-threatening issue. I share this just to give a glimmer, not that this is proof that it works, but in this one case, it really showed me some of the benefit coping with distress and challenging medical situations, even while they're happening, may be possible with these medicines. So backing up just a little bit of why is this important? If we want to look at data of psychosocial distress in patients with serious medical illness, the best data is in cancer. And so if we look at these studies, this is still one of the largest study I'm aware of, over 10,000 participants, patients with cancer. It's pretty old, but it's still one of the best. They found a rate of actually clinically validated major depressive disorder is about 15%. We can see on the order of maybe like 1 in 4, 1 in 5 will have major depressive disorder in cancer, but we had even a higher number of folks with adjustment disorder. And if you look at mood disorders overall, it's almost 40% in this sample. So we have to think about what are we missing if we're only looking for classic major depressive disorder. So I like this term, depressive spectrum disorders, that was discussed in a paper by Caruso and Breitbart a few years ago, really talking about mood symptoms generally in patients with medical illness. And my sort of most favorite, mood disorder on that spectrum to look at is demoralization. So demoralization is a syndrome of poor coping, helplessness, hopelessness, and a loss of meaning and purpose in life. This is a nicely operationalized version of existential distress. And it's actually pretty prevalent. There was a nice meta-analysis published a few years ago looking at advanced progressive illness in adults. Up to 1 in 4 to about a third of patients can have clinically significant demoralization, which means that they probably have a desire for hastened death or suicidal ideation, a lot of physical symptom burden, and they're plagued by poor quality of life. We don't really have good data on pharmacotherapies for this, but we do have a number of now actually manualized behavioral therapies, psychotherapies for demoralization in patients with serious illness. And one of my sort of favorite and one of the most recent studies is on meaning and purpose therapy developed out of Australia. This is an existential, brief, only 6 sessions of psychotherapy over a few weeks. This trial was multi-site with over 100 patients with advanced cancer. They had to have at least 1 year of prognosis or greater, and they compared this versus usual care in the oncology setting, but without psychotherapy. They did not actually find a benefit on demoralization itself that was statistically significant, but they did find positive outcomes on post-traumatic growth and meaning in life, which really overlaps with demoralization. So some positive effects from this brief therapy, but maybe not everything that we would look for. And this, for me, is one of the reasons why we look to psychedelic therapies, a medication plus a talk therapy that can hopefully address these existential symptoms in patients, even with medical comorbidities. Now, I'm sure you've heard a lot about psychedelic therapies over the last few years. I do think it's important to recognize that this did not start with Tim Leary. That's not where this actually was invented. And if we look back and we engage in the social science literature and even the earlier biomedical literature, we know that the first psychedelic that was really studied in the classic psychedelics was mescaline, actually in the late 1800s. So long before Leary and Harvard, mescaline was studied and used in different settings. A lot was learned from Native American communities in North America that were using peyote as a religious sacrament. And there's actually a pretty rich literature of biomedical investigators in Latin America studying different traditions in the mid-century, trying to understand what these substances are and how they can be used for healing and support. One of the early indications of modern biomedical research with psychedelics is end of life and palliative care. So Sidney Cohen, who was right here in Los Angeles in the 1950s, studied this. This is a quote, not from a peer-reviewed paper, it's actually from Harper's Magazine, but he treated a patient, he called her Irene, who had cancer, and one of her reflections in this, popular media piece after she had received LSD-assisted psychotherapy from Dr. Cohen, she had said this, yes, I see what you have done. You have stripped away me. This is a touch of death, a preparation for the big one when no me will be more permanent. I share this quote to stop and just think about what that might mean for our patients who are having such a profound, potentially altered sense of themselves, what permanence might mean when they are gone, and what that might do for them or provide for them psychologically in a clinical controlled setting. If we can offer such experiences and how theoretically that may help decrease distress about death and dying and what people are losing as they're moving towards the end of life. Now, this early work in the mid-century spawned some very important work that started here at UCLA with my friend and mentor, Dr. Charlie Grobe, when he demonstrated it with this publication in 2011, the safety and feasibility of a moderate dose of oral psilocybin plus talk therapy. They showed that in advanced cancer patients with anxiety, that this could be done. That in itself was a feat. And even though it was a pilot study, it was so important for opening the field of doing this therapeutic research again in the United States. Subsequent to that, researchers at NYU and Johns Hopkins in 2016 published these randomized controlled trials of oral psilocybin plus talk therapy for patients with a history of cancer who had either anxiety in the NYU study or depression and anxiety symptoms in the Johns Hopkins study. And this really was kind of like the bedrock for me of psychedelic therapy peer-reviewed literature up until about a decade ago. And still, the study from Johns Hopkins is one of the most, I think, foundational studies we have in the field, specifically of end of life and palliative care, because they had what is still today, 10 years later, the largest study in this population, and I think some of the most robust data. So they found that of patients who had, again, a DSM diagnosis of depression or anxiety symptoms, 51 participants, average age was in their 50s. About half of them had used psychedelics previously in their life, but they found this. If you gave structured psychological support plus either a high dose or a very low dose of psilocybin that shouldn't have psychological effects, and they knew that they were going to get psilocybin, but they didn't know the impact or the dose, that if you look at the red line, the decrease in depression and anxiety symptoms at post one, which was 5 weeks after the medication, was far greater in the people that got the high dose of the drug compared to the people that got the low dose of the drug. Nicely, also, they showed that there was improvement in the blue line, which was people who got such a low dose of psilocybin it shouldn't have an effect, but they had psychological support and they were in a trial. So you see benefit, but after the crossover, which was between post one and post two, you get catch up. Basically, if you later get the high dose of psilocybin, then you can get your symptoms down to at the same range as patients that got high dose psilocybin weeks before. And impressively, they maintain these benefits at 6 months later. So zero serious related adverse events, nice demonstration in a blinded RCT, and still the best data in the field. We followed this up at UCSF a few years later, not working with cancer patients, but working with long-term AIDS survivors who were older, meaning over the age of 50. And we worked with them for a number of reasons, but we did this study a little bit more as like a community engaged study. So we had consultants from the community who talked to us about the design before, during, and after. We planned it as a group, given again all the isolation that was going on in the community, and also because of the group aspect often used in community settings outside of medical uses of these substances. It was only an open label pilot, so we were really just demonstrating in what was the first modern clinical trial of psychedelic therapy to use group, since this work started in the last couple of decades. So there was no control. We were just showing safety and feasibility, and we worked with clinically demoralized individuals. We used a very similar kind of inclusion-exclusion criteria to make sure that this would be safe. We used a dose comparable to what had been done in the cancer studies for the first cohort of 6, where they had 4 sessions of group therapy, and then in 2 weeks, everyone had an individual psilocybin session with two facilitators or therapists, and then we followed up again in group later for 4 sessions. And some of the feedback we got was they actually wanted more time together. So for the next 2 cohorts of 6 in this total N of 18 pilot study, the next 2 cohorts of 6 had 4 group therapy sessions, individual psilocybin, and then 6 group therapy sessions after. We also had a slightly higher dose in those final 2 cohorts. And what I want to share is that we had 0 serious adverse events. We did have adverse events, but just for the sake of time, we had 0 serious adverse events like hospitalization, life-threatening injuries, and we showed that this was feasible. Because again, that was our scientific aim, was demonstrating this. So of the 18 people that started this, all 18 stayed with us through the end to give us safety data. 95% of the group therapy sessions were attended, so a highly motivated group that were able to follow up. 1 did discontinue due to an adverse event after the psilocybin session. They didn't follow up with all the group therapy sessions, but we did collect safety data. And so we showed that this was possible to do this group work. And thankfully, the field has actually grown so much since then, because of the work that Charlie did, the early work at NYU and Johns Hopkins, and in our group study. We now have, these are academic institutions in the United States, Europe, and Australia that all are or have recently conducted investigator-initiated trials of mostly psilocybin, but psychedelic therapies for patients with serious medical illness. So the field has really expanded. And luckily today I get to work with Mike Mackinson, who's here, Charlie Grobe and the team, Ziva Cooper, on this multi-site study that we are currently conducting of psilocybin therapy plus meaning and purpose therapy that we mentioned before, for demoralized adults near the end of life. And maybe in a year or so, we'll come back and share the results of that. To move along, though, I'm not going to get into that data as much as I'm trying to give us a sense of where is the field at right now. We are in phase 3 trials with a number of different psychedelics, including MDMA, psilocybin, and LSD. These are the indications and the drugs that are being studied. But I just want to mention that even though none of these indications are an end-of-life distress, 3 out of the 4 companies that have made it to phase 3 trials with psychedelics actually started as nonprofit efforts to develop psychedelic medicines for end-of-life distress. They have all over time shifted to moving towards PTSD, treatment-resistant depression. But I just want to highlight that I think there's sort of a core clinical application here that is reflected in where this industry comes from, but which has been left aside, and which is all the more reason why academic studies are important and why we think about other ways that this might be legally safely accessible for patients seeking this out. And so a kind of a new thing in the field is that there's a number of countries, actually, a number of jurisdictions that are now permitting compassionate use of psychedelics for end-of-life distress for patients with life-threatening terminal illness. Switzerland has actually been doing this for decades with a few different psychedelics. The USA did this briefly with MDMA for treatment-resistant PTSD, and that program ended. Canada, Australia have these sort of restricted access programs, and then Germany is going to start soon too. For me, this is a new frontier of what is actually happening for patients clinically now, and leads me to the next area I want to look at, which is thinking about novel spaces outside of just trials that patients are accessing this, and can we engage with that with science. This is where we're going to move to opportunities for regulatory science with psychedelics. So to define that, I take this from the FDA's website, where they have a whole extramural program in regulatory science. And they say that it is the science that develops tools, standards, and approaches needed to assess the safety, efficacy, quality, performance of regulated products. And importantly, this allows regulators like the FDA to understand and assess risk, prepare for public health emergencies, and ensure safety or reduce harm from the products that the public are using. For me, a question that I sit with is, how can we apply that to psychedelics today in 2025? 2025 is rather different from even 5 years ago because we have had regulatory shifts in this country. Starting in 2019, the city of Denver deprioritized criminal enforcement of controlled substance laws, specifically for psilocybin. The whole state of Colorado followed with decriminalization in 2023. But we've also had other jurisdictions do this. Oakland also deprioritized natural product psychedelics in 2019. Oregon had a decriminalization period of all drugs for 3 years, and there's a number of other municipalities. You can see it with the black dots on this map from psychedelicalpha.com, showing the different cities that have followed. In addition to deprioritization or decriminalization, meaning not pursuing laws or making it now no longer a criminal offense to possess and use psychedelics, we have three states in this country that have passed laws saying that the state is going to provide a regulated structure for adults to use psychedelics, legal according to state law, not federal law, but state law. Oregon, Colorado, and then New Mexico is coming on board soon. There are state services, if you go to the Department of Health in these states, that are implementing this. And this is just a phenomenon that led our group to write a commentary over the last few years we published in the American Journal of Psychiatry, trying to suggest a novel taxonomy for how to think about these policy options. It really doesn't work in the real world to use binaries right now to say legal or not, therapeutic or not. There's so much of these different spectra. And so our proposal in this commentary was to think about a particular psychedelic use. If you want to understand its regulation and its implications for public health, to think about, where is it on the spectrum of therapeutic intent? Is this fun? Is this treatment? Is it somewhere in between? The spectrum of legality. Is it actually legal in the state but federally illegal? Is it a actually approved like religious use that has a DEA registration? There's a number of churches that have those. That's different from a legality under medical use. And then frankly, how structured is it? And by that we mean you may have like a very legal ketamine clinic, but it may be sort of very open for how they're using it, versus you may go to some ceremonial settings where they're very disciplined. Think about Native American church. They have a lot of rituals and rules about who can do what. So if you are open to this idea, I think this gives us a more textured way of thinking about regulatory options for psychedelics and how to evaluate them and think of their impact. But to understand the impact of different psychedelic regulations, this is challenging. And as a number of you know, who, for instance, work in cannabis or even just walk around in California in any city, how do you regulate natural product substances that people like using? So you can grow them, distribution, production. This has been very hard for us to sort of manage. And there's something very similar with mushrooms that people can grow in their home, in their backyard, that now we're seeing in dispensaries and all sorts of shops around the state. If you want to regulate psychedelic care, for me, I really think of this as not just a medication or a pill, it's a procedure. There's all sorts of forms about the setting in which it's done, the training that people have. And so thinking about what goes into regulating procedures versus medications makes this also more challenging. And frankly, I think the allopathic medical system has been kind of negligent of psychedelics for many years. We didn't really study them. I didn't learn about them much at all in med school. And so we don't have a lot of familiarity with them in the medical profession like we do with other classes of substances. And frankly, there's people out in the community that are not licensed healthcare providers who I think have more clinical experience with these substances, what the effects are, what's normative, how they can hurt people, how they can help people, more so than we do in our professional medical settings. And so how do we build those bridges with that sort of community expertise, and use that for research and the betterment of health? This is like a sort of a new frontier. Um, in order to study this, in order to really understand how these different regulatory systems and ways that people are accessing these substances can affect population level health. There's a lot of work we need to do. So this is something that my group has been looking at as just the limitations of, for instance, basic surveillance mechanisms. We have a lot of surveys that ask about substance use, and they ask some questions about psychedelics. We can do health services work that tries to capture who's using psychedelics in our systems. But if we're just looking at ICD-10 codes, we're not going to capture a lot of people's encounters. There's the NISDA survey from SAMHSA for the longest time only asked about life year use of psilocybin. So that's great. We have a nationally representative survey about health and substance use. But if you just say, have you ever done this? How do you want to correlate, recent health impact if you don't even ask about last year, which they only started doing in this last data set? And then we really don't have consistent taxonomy. Are these hallucinogens? Are they psychedelics? What about the entactogens? Is it all the same? What are we even measuring? So it makes it hard to use our data sets. And one sort of example I find helpful for thinking about this is this nice paper from Rocky Mountain Poison Data and Safety from Rick Dart from just last year, where they have a nationally representative bespoke survey that they do of substance use. And they ask people about their rates of misuse or non-prescription use of ketamine. So if you just measure ketamine and treat it all as the same, that's very different if it's generic ketamine versus S-ketamine when you're looking at rates of non-prescription use. So I think taxonomy is really critical, and I don't think the field is quite doing that in a specific enough way. Positive thing, though, to share is that we are seeing new data systems come forward that I think can help us look at this data in a more useful way. So Oregon was the first US state to pass a law allowing for state-regulated adult use of psilocybin. In that law, however, it was written that they were not going to do statewide data collection. So they actually had to catch up and a couple of years later pass a separate law, which was SB 303, that mandated aggregate data collection from all what they call the psilocybin service centers, where you have to go and get the state-regulated use of the substance. So they're only now 2 years later after they started getting that data to look at what these outcomes may be related to taking the substance in the state regulated setting. This is one of the reasons why we have academic labs like out of OHSU and University of Colorado standing up longitudinal cross-sectional surveys to look at use not just from state-regulated settings, but also from people using in non-regulated settings. And really, this is kind of our best data that we have, because again, the national data sets are not sufficient for understanding the texture of which substance are you using, how long ago was that, and how does that maybe correlate with other health outcomes. This sort of deficit of our knowledge base is a big part of what promoted a a contract that I and my collaborator at UCSF, Jenny Mitchell, are just now finishing up with the FDA. I mentioned that the FDA has an extramural funding arm in regulatory science. I think we were probably their only regulatory science contract on psychedelics and health. And for the last few years, we ran this contract, which had a few different protocols that in different ways were community engaged. Some of them were qualitative, some of them were quantitative, looking at real world's risk and benefits of psychedelic use in non-medical settings. And our goal really was to try to get data that can inform clinical policy research decisions about use, kind of thinking about sort of if we go to phase 4, let's say we get, regulated medical products with psychedelics at some point, they're going to be much more widely used. What is that going to look like in more general populations to understand real world risk and benefit? And of the different protocols we ran in that contract, I'm going to briefly tell you about this one that was led by my colleagues Juan Carlos Montoy and Ralph Wong, who are emergency medicine physicians and researchers at UCSF. So this was our attempt to develop a method to more usefully understand the impact of psychedelic policy changes in what we called an enriched natural experiment. Basically, Oregon, when they passed this first law in the US for adult regulated use, went through a period where they had decriminalization of all drugs. And then they started state regulated access to psilocybin. The decriminalization actually went away because Oregonians voted that out after a few years. But you have this nice sort of stepwise progression of policies. And our question was, how can we assess sort of more like immediate serious harms, psilocybin and psychedelic related healthcare encounters using existing health services data? So it was very ambitious, and I'm glad that our partners put up with us. But we worked with 3 different healthcare centers in Oregon: Kaiser Permanente, Legacy Health, and OHSU. The PIs for the different sites are there. And we got data from 11 different emergency departments and 1 psychiatric emergency system in Oregon that was transferred to us to create one large data set that is not representative of the state of Oregon, but it was these sort of large sort of urban areas where we thought we would catch emergency department encounters related to psychedelics so that we can track change over time as policies change, and so that we could figure out how to do that again in this geographic area enriched for what we suspected psychedelic use given policy. It was very complicated. We actually at first wanted to do a difference in difference design, looking at as different counties went online with offering these services, could we compare that to other counties that weren't starting to offer these services? But if you look at that map, I forget from when this map was taken, but red are locations that were not offering state regulated services. Green is where they had gone active. So some whole counties started offering this. Some counties did not do it, but certain cities in the county did offer it, and then vice versa. So our attempt to do a difference in difference approach, we really had to just give that up, and we moved towards an interrupted time series. But our goal was to try to track geographically and temporally what's going on using this existing data. If you look at health services data on psychedelic use now, you'll often have reports that look just at what we called core codes, or sort of ICD codes that are clearly related to psychedelics. So there is a billing code for LSD. There is a billing code for MDMA. There's a billing code for psychodysliptics, which I don't think anyone actually uses. And I work in an emergency room. I never code for psychodysliptics. But you can easily capture these, and you think that we think they're relevant for psychedelic use. Our suspicion was that there's going to be many more encounters that are billed as unspecified psychosis, unspecified mood disorder, substance-induced mood disorder, et cetera. And so we actually searched for these as well in the different systems by creating a list of search terms that if these search terms were in the text of the encounter, that gave us a positive hit for what we're calling these peripheral codes. We then had a manual refinement process where we had a certain window around that search term where we looked for, okay, Was it acid, meaning like it was actually LSD, or most of the time acid was like lactic acid or various other medical acid terms, very non-specific, but actually, you know what? Quite a number of times, acid in the free text actually led to LSD encounters that were not being captured with the typical ICD-10 codes. So we went through this manual process to remove things that were not actually related to psychedelics. And what we ended up finding is, I'm going to show some unpublished preliminary data just from one of these health systems. Again, these are not our final data, but just to give an example, when we looked at totaling this all over about a 10-year period, is that if we looked at the codes that are like LSD poisoning, MDMA poisoning, we call those the core codes. You know, this one site only had 67 of those over 10 years. But if we did this, we found our search terms, that gave us over 2,000. And yet, once we do the manual review, that drops that to 1/10. So these what we're trying to do here is really develop a method and try to refine that and figure out its specificity and sensitivity. Um, we think that this is working pretty well. This is kind of what we would expect. Again, are just preliminary data, but these are mostly young adults, 18 to 34-year-old, white, non-Hispanic males. Also makes sense for Oregon. And yet, what we're doing now is trying to put all this together. If I can sort of give a summary here, if we just use the codes that people are using now in health services studies, we're going to get X. We're probably missing 2 to 4X of what's also coming in just through the what we can see with the search terms. Once we actually refine those, and we've been doing some positive predictive value sampling to make sure that that's a valid method for us. So we're maybe detecting maybe like 1/5 of what's actually coming in through the emergency department. And this is something that we're going to sort of be able to report more on soon once we kind of harmonize these data sets that we're doing now across the institutions, from which we'll be able to characterize who are these patients, what happened in these encounters, what was the disposition, inpatient, outpatient, et cetera. And then we're using for right now, because we're still figuring out the validity of our search process, at least for those standard ICD-10 codes, we're running our first interrupted time series to see, as policies change, can we, in these health systems, see a change in psychedelic-related emergency department encounters over time. Our goal is that we'll have a better sense of what the public health impact just from the core codes can be, while we're also figuring out what are the overall incidents of these, for me, a serious adverse event landing in the ED, right? Because of psychedelic use. And then my goal is that we can actually develop a syndromic definition of different ICD-10 codes, or at least a proportionate number, that if we get so many ICD-10 codes that are psychedelics, we know we're missing a certain amount, and we can apply that to other data systems that already exist. So if the CDC will still fund its National Syndromic Surveillance Program, which gets data on emergency departments all over the country that it rapidly reports, we can do this analysis in that data set with ICD-10 codes we think are more meaningful. We've actually asked them if they would look at this with us, but they were really clear. We don't have a validated syndromic definition, but if we can get that, we can use these powered systems to understand public health impacts much better. So with that, I want to transition a little bit more towards looking towards the future. If we are thinking more about wanting to understand real world impacts of psychedelic care in use, certainly we have medical models that we said are in phase 3. We may in the next few years have FDA regulated psychedelic medicines, but we don't even have to wait for that to look at what's happening out in the communities now. So if we look at outcomes of compassionate use, like we mentioned before, these state services that, again, we now have 3 states with these laws, and we may have more soon. And frankly, also religious use, which it's less frequent, but there are, again, DEA registered churches that offer psychedelics like ayahuasca in this country, as well as Native American Church, which for decades has been providing peyote ceremony in a non-DEA registered way. we can do observational studies in these settings, or even maybe pragmatic trials in like the state regulated settings to understand these impacts. One concern, obviously, if we're doing observational data is, what are we really coming away with as far as causal inference? So we can get all the correlations we want, but how do we really know what the impact of these interventions are? Clearly, as with other areas, if we're working with a hidden or stigmatized population, many of these settings are still federally illegal, and we are asking people about benefits and harms. It's always challenging in these settings to understand, when people are verbally telling this, or do they trust us? Do they feel like it's okay to actually share their experience and for us to measure that in a robust way? Um, and I would like us to start thinking, this is something that I hope to do over the next few years, is thinking about other regulatory solutions that are maybe new or hard to do, but can help us understand real world impacts of psychedelics in federally legal ways. So if we go back to the Controlled Substance Act, this is something I've learned from a number of attorneys I've talked to for the last few years. Yes, we know that it has created a number of schedules. And so most psychedelics are Schedule 1, meaning they have no currently accepted medical use, and they have a high potential for abuse. But within the Controlled Substance Act, there also is this clause that the Attorney General can stand up research projects. The Attorney General could authorize that we essentially create in a state that wants one of these programs a federally legal way to understand how to prevent diversion if you provide this to certain types of patients, or if you offer it with certain structures around it. This is totally possible. I've never seen this happen in psychedelics. I don't think it really will, but this is my understanding, is this is essentially how methadone was rolled out, is initially as a federally allowed research program for addicts to get their narcotics. And so we could imagine, if there were top-down interest from the federal government, a process like this. I think what's more likely to happen is that we're going to see how another federally legal way for patients possibly to access psychedelics is the federal right to try law, which was only signed into law in 2018, but allows a treating physician and a patient with serious and life-threatening illness to request an investigational drug. The courts have said that, the Controlled Substance Act does apply, so you do need a Schedule 1 registration in order to access this for treatment, which has been a barrier to getting those, to just provide a patient a single use of a drug before they die. But actually, as of this year, we have this new regulation called Halt Fentanyl, that even though it's mostly about making fentanyl harder to get, it actually makes it much easier to get Schedule 1 registrations for research. And so a hope that I have is that this makes it feasible to actually do implementation science under right to try, where again, because right to try says patients can access this, it is approved for that. We could study how that can happen in a safe and effective way. And so I am partnering. This is not to endorse a company or say that their product works at all. But there is a nonprofit drug manufacturer I work with in Arizona, who has DEA registered psilocybe mushrooms, and part of their goal is to provide this to dying patients. And so we are trying to stand up a way to study implementation under right to try, where imagine we have only so many Schedule 1 registrations in the country, people who already do this research. With Halt Fentanyl, we could increase the number of registrations so providers in a more generalized setting who are maybe doing this for the first time could access this for their patients. And then we can ask questions in an open label and more pragmatic way. What is the appropriate training that is needed in real world settings to offer this? What are the adjunctive therapies, meaning and purpose therapy, CBD, et cetera, that it makes us safe and appropriate for our patients? What about dose? Not one trial where everyone gets 25 milligrams. Maybe patients need something different. We need to be in a real world setting to ask that. And we can do this so that we can inform both medical and state regulated systems. I want to make sure there's time for questions. And so I just want to leave us with, I feel, and I think that the data do show that there's a lot of promise of psychedelic medicines for treating distress in patients with serious medical illness or near the end of life. We know that the regulations for natural products of psychedelics are really outpacing the science for how to use them as treatments. But I think regulatory science is an impactful way for us to kind of catch up with some of those novel access pathways that are out there so we can inform decision making. And then hopefully we can, in doing regulation engaged research, really understand the true parameters of these medicines in a more efficient and generalizable way, particularly for patients who are near the end of life. And with that, here's my references. And I just want to say thank you.
Thank you so much, Dr. Anderson. Wow, I had heard pieces of this over the years, but not had it put together in this way. And of really understanding how the field of psychedelics research calls on someone who has the very high level of sophistication in clinical research, plus the acumen as an anthropologist, if I can claim you, to do research that's really targeting real world, complicated social and political landscapes. Thanks again. And I can see we already have some questions from our internet audience, which is quite large. But I wanted to give those who braved the rain today to come in person a chance to kick off our discussion. Um, just wondered if any of you wanted to start us off. Yes, Dr. Cooper.
Thank you. It's great talk, Dr. Anderson. So your group therapy protocol and study was really interesting. And for a while, before I read your paper, I thought that maybe the group therapy part of it was that the psilocybin was actually given in a group setting.
Mm.
And I'm wondering, so in your particular protocol and in your study, which has demonstrated feasibility and improvements over time, has there been a movement to, under controlled procedures, looking at group drug administration sessions, not just group therapy?
Yeah, thanks for the question. So maybe people heard you, but in our study, we had group therapy before and after an individual drug dosing, and have the studies moved to actually have group administration of the drug. So that's actually exactly what has happened. There's been a number of small single site studies that have moved towards simultaneous dosing all in the same day and actually group administration. And so that is where the research is moving, showing that's also safe and feasible. We actually intended to do that. And then we were kind of chastised by some of the senior researchers at the time who said, this is already risky enough to do group, do individual dosing. And so the max that we actually did was 2 people having their medication in separate rooms on the same day. So they could at least see each other at the beginning and end of the day, which I think was actually a powerful experience for some of the patients. But yeah, that's where the field has definitely moved, group administration as well.
It seems like that might help to improve feasibility as well when thinking about how to implement this type of work.
Absolutely. And there's that model is what we're already seeing in the states where this is happening in a state regulated way, and certainly in a number of community settings that are not regulated. Yeah.
Great, thank you. So along lines of feasibility and access, we have a question about, based on the evidence of benefit for older adults, where are we in seeking Medicare approval for psychedelic assisted therapy? And this person comments that geriatric psychiatry patients with demoralization or major depressive disorder could potentially benefit, but few have the financial resources outside of Medicare.
Got it. Great question. I mean, I think we're going to have to see at least one psychedelic medicine that is not ketamine or a ketamine analog to get FDA approval before we understand how Medicare will and won't cover this. Though I can say a colleague of mine who works in healthcare administration was at the California annual meeting of healthcare providers. And she said one of the big discussions this year, just a couple of weeks ago, was how are we going to do coverage for psychedelic medicines? So I think it's being figured out, but no one has a clear answer yet.
Along the lines of policy landscape, which is rapidly changing, I know some people are going to be curious about RFK, who has a slightly different take on psychedelics. And I wondered if you wanted to say a few words about that.
Well, I think you guys know him better than me because he live here. I've never met him. It does seem that the HHS, Health and Human Services, currently wants to find ways to improve the efficiency of psychedelics research. But I don't know. I can say that the NIH does have RFPs now for psychedelic trials, and we actually just received notice of award for one from the National Institute of Aging a few weeks ago, and so the NIH still is supporting this work and probably will continue to do so.
Thank you. Oh, yes, Dr. Evans.
Something interesting, sort of difference between the effects of synthetic psilocybin versus mushrooms. Is there, I mean, obviously there's psilocybin and other things in the mushrooms, but is there a big, I mean, what are people using when they do these drugs?
I see. Yeah. So is there a difference synthetic psilocybin versus the natural product mushroom? And I have not seen that head to head. I know that there are, so Sioux Cicely in Arizona is starting the first trial of her psilocybe cubensis mushrooms in humans, and other studies like that have been done like in Latin America. But frankly, it's probably a pretty similar effect, but we haven't seen that studied. Most of these trials are with synthetic psilocybin. Yeah.
Okay, so we're getting a few more questions here online. Why don't we start with the last one? Because I think it kind of dovetails. Is there a rationale to why psilocybin has been historically used for major depressive disorder and MDMA for PTSD?
There's, I think, definitely there's a rationale for why psilocybin has been used for depression, but MDMA for PTSD. And yet, honestly, there's also been studies, I think, of both looking at potential benefits. So it's not like one has to be used for the other. But part of this is also political. For many years, psilocybin was studied by the Hefter Research Institute affiliated investigators who were more focused on mood disorders. And what was then called MAPS was developing MDMA for PTSD. And that's how they started. But again, MAPS, actually, their very first trial was in cancer patients with anxiety with MDMA. So it's not like, you can only do one or the other.
Thank you. Thank you. There's another question that is more along the lines of cross-cultural psychiatry.
Yeah.
And I'm going to combine it with a question of my own. So the question that came in online is, do Europeans have a slightly different view of death versus Americans, especially urban, that impacts their ability to deal with depression and cancer? I'm just going to tag on a question that I have about something you alluded to, set and setting. The mindset of the person when they take a psychedelic medication and the setting that they're in, what surrounds them. Because I know that there has been a lot of discussion about how important those are to the outcome, the difficulty of capturing that in studies, particularly clinical studies of psychedelics, which is where a multidisciplinary scholar such as yourself may have, some answers. But I wonder if maybe we could put those two questions together about cultural differences when it comes to concepts of death and setting in the clinical use of psychedelics.
So not having done an ethnography of death and dying beliefs and attitudes myself in different European countries, I think it's a super rich question. And I think we have a nice opportunity to look at that, given that there's a pretty similar trial to the one that we're running here at Charlie Grove, multi-site psilocybin near the end of life. There is a trial multi-site with non-cancer life-threatening illness in Europe. And so even though I think some of the clinical settings will look pretty similar, the different cultural backgrounds of folks in these different countries may actually shine some light on if we are giving similar treatments with similar doses. If the outcomes are different, I would love to see the qualitative data on that. But I would say in some parts of Western Europe, they definitely have more access to psychedelics. Medical aid in dying has been more sort of in these cultures and accepted for a while. And so there may be a rather different approach to experience to help you cope with death if you have a different foundational understanding of death in life to begin with.
Thank you. So just to add one of my other questions, my own exposure to psychedelics trials happened when I was in training at Bellevue Hospital back in the late 90s. Well, actually, it was early 2000s. You showed a photo on one of your slides of one of my mentors, Steve Ross, who did some path-breaking trials of psilocybin for end-of-life anxiety and also in substance use disorder. Mm-hmm. So that is my question. I was training in addiction psychiatry. And I wonder what you would have to say about substance use disorder and psychedelics, where some of, just big picture, where some of the promise is, where some of the perhaps complexities lie in that therapeutic indication.
So I'm very excited about this area. We definitely, one of my colleagues at UCSF is currently doing a study of ketamine-assisted talk therapy for people with methamphetamine use disorder. There is some good data in the field. And particularly, however, with patients with substance use disorders, I would hope that we are very much focusing not just on the drug, but all the psychosocial support around it, not just during the trial, but where do they go after the study? If they are already likely to have challenges sort of modulating their engagement with euphoria, if we are going to introduce these substances, I think we need extra care for what that talk therapy, the group therapy, the community support will look like to keep that really healthy for them.
Thank you.
I just-
Oh, yeah,
I think we have 2 more questions. Your question.
Dr. Mackinson.
Yeah.
Well, maybe this is too big a question, but very, very interesting to me. One of the implicit themes here is the FDA and the FDA's constraint of the medical model and disease-based indications. And of course, the drug companies have the resources to take these up: depression, PTSD, et cetera. And so where do you think academia can fill in the gaps outside of the FDA mandated, disease medical based model for interesting ways to study psychedelics, some of which you alluded to?
Yeah, so how can academic research fill in the gap for what is not being pursued by industry and what the FDA kind of structures for research? Even when there's FDA approved psychedelic medicines, my guess is the vast majority of Americans using psychedelics will not probably use them in medical settings. We don't have that many people using dronabinol compared to people using cannabis products. And so I hope that, with the anthropologist in me that says, let's go ask the communities how they're actually accessing it. Are they going to Oregon? Are they going to a dispensary? Are they growing it themselves? And then come up with good questions around what they're actually doing. Otherwise, we're just going to be, looking at the easy thing to find, but not understanding what's going to impact public health, which is the use that people are actually choosing.
Oh, and we
Yeah.
may have time for one last comment from Dr. Evans.
I've been interested in the plastinogen effect versus the hallucinogenic, whether you actually need the psychedelic effect to actually have the positive effects on actual health. And I think that's one area which is very academic and really needs to be sorted out, because if it's just plastinogens, then you don't really need the hallucinogenic effects to actually make you have therapeutic effects. So how's that research going on? I don't know if you've been following it, but I think it's really important.
Yeah, where's the research really on mechanism and whether or not the subjective experience truly mediates clinical change? I think this is, there's a lot of basic science research on the sort of plastinogen effects and how to translate that into human work. I think it's shifting. There's been arguments that it's really not necessary, but even some of the trials, like the phase 3 trials, are showing that maybe there is some mediation of the subjective effect. But how do we measure that? With like one scale that just says intensity of mysticism is maybe challenging to understand the true character of the subjective effect. So people are looking at it more, but we still have to accommodate for it during the clinical treatment, because that's a big part of their experience until maybe somehow someone tries to take it away.
Please join me in thanking Dr. Anderson.